Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program facilitator and will present your questions to our experts. This evening, we'll hear from experts in neurology, neurosurgery, and neurorestoration as they discuss stroke prevention, treatments, and rehabilitation. We'll cover essential strategies to reduce stroke risk, the latest advancements in stroke treatments, effective rehabilitation techniques, and ongoing clinical trials that are exploring new methods for stroke prevention and recovery. Well, thank you so much for submitting your questions in advance of tonight, and we'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. You will also have the option to ask your questions throughout this webinar. And finally, due to hospital guidelines and privacy, please note that we are unable to comment on specific cases. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. Mihail Saraya with neurology with the Raphael Center for Neurorestoration, Dr. Rena Ten with vascular neurology, Dr. Shopi Middle with vascular neurology, and finally, Dr. Ritam Ghosh with vascular and endovascular neurosurgery. Well, thank you so much for joining all of us. I will give each of you a minute or two to just say hello. You can provide a little background information about yourself. So, Dr. Soraya, we will go ahead and start with you. How are you doing this evening?
I'm good. Thank you so much. Thank you for this opportunity. I'm a physician scientist, so I'm a PhD trained neuroscientist and also a board certified neurologist. And I'm honored to be inside the Jefferson Moss McGee system, where I work with these wonderful colleagues on this Zoom to help develop the treatments of tomorrow.
Thank you so much. We're so excited to have you here this evening. All right, Dr. Ten, how are you doing this evening?
I'm doing very well, thank you. Hoping everyone is doing well as well.
Great. And if you could provide just a little background information about yourself, that would be awesome.
Absolutely. Thank you. So first of all, thank you all of you and for the opportunity to be here this evening. I'm a board certified neurologist and also stroke neurologist, which means that I take care of a complex variety of neurological cases, including stroke, that affect the brain and the spinal cord. And it's a pleasure to be here with all of you. I guess the purpose of this webinar is that you are in a forum that is okay to ask questions, and we hope to address all those questions and concerns. So thank you for your time. Pleasure to be here to talk about my favorite topic, stroke.
Absolutely. Thank you. All right. Up next, Dr. Middle, how are you doing this evening?
Good evening, everyone. Thank you, Sarah, for this opportunity. And it is my extreme pleasure to be here and talk about, as Dr. Den mentioned, our favorite topic, stroke. I am a stroke neurologist by training, and I am also the division head for telestroke and teleneurology at Thomas Jefferson University Hospital. And as part of our system, we do provide care for thousands of stroke patients across the state of Pennsylvania. So answering the questions today for our patients would be extremely important to help them with their recovery process and understanding of this condition, stroke.
Absolutely. All right. Thank you. And last but not least, Dr. Ghosh, how are you doing?
Hi, good evening. My name is Ritam Ghosh. I'm a neurosurgeon here at Jefferson. I work at Jefferson, New Jersey, in Washington Township, as well as Center City. And I see patients at Cherry Hill, Washington Township, as well as Center City. And we also cover call at the Torresville campus. I'm here today to kind of speak to more about the surgical aspects of stroke. A lot of people don't realize that really nowadays stroke can be a surgical disease, both in the treatment of stroke and the prevention of stroke. And we work hand in hand with our neurologists to provide the best stroke care for our patients. And I'm happy to talk about that today. So thank you for having me.
Yes, thank you for joining. And I know we received a lot of questions, so we'll go ahead and dive into it. But yes, thank you all for submitting such great questions. Okay, so to kick us off, Dr. Surya, we will start with you. So first question for the evening. Is there a feeling or sensation that would alert or signal an individual that a stroke may happen?
Yeah, so the word stroke is like a stroke of midnight. It means something that happens suddenly without warning. And the ones people are usually most familiar with is like a sudden change in strength, like face drooping or weakness in the arm or difficulty with speech. So anything like that, or sudden numbness on one side of the body, sudden change in vision, or in certain cases, a really, really sudden severe headache. Any of those things could be a sign of a stroke. And sometimes symptoms go away, and that could be called a transient ischemic attack, which is sort of like a some people call a mini stroke. But if any of that happens, that this sort of sudden stroke of event happens, that's a reason to call emergency EMT 911 and get help.
Okay. Thank you. Let's talk a little bit about how strokes happen. This next question, this person is wondering, when someone has a stroke, is it because the blood is restricted or maybe even forgets to flow in a certain channel of the brain?
Yeah, so one can think of the channels of the brain as the blood vessels of the brain, as sort of like pipes in your house. And so if the pipes get blocked, that's called an ischemic stroke, so that the blood can't get where it needs to go to deliver oxygen. Or the pipe can actually burst, it can explode, and then the blood leaks out, and that's a hemorrhagic stroke. And that leads to bleeding in and around the brain. But both of them have the same net effect, which is that the blood that's carrying the oxygen that we breathe in can no longer reach those brain cells. So you can think of it as channels forgetting, but it's really a mechanical thing, and that's actually something where someone like Dr. Ghosh can for when it's a ischemic where the pipes get blocked, there are actually techniques. If you get soon enough, they can literally unblock it, very much like unblocking a pipe. But those are the two main kinds of stroke. And unfortunately, if too much time goes by, we are only given the brain cells that we're born with, really. And so if there's been too long without oxygen, they will die and they won't recover, even though thankfully a lot of the other brain can recover. And a lot of stroke care is about trying to preserve what's left.
Okay, thank you. And appreciate that analogy with the pipes. It's helpful to visualize. So thank you. All right. Turning to the next question here, Dr. Ten, this one is for you. After having a stroke, what's the likelihood for another, and what's the best way to avoid another one?
Yeah, that's a great question. And actually, as I'm on call this week on service, that's a question I get a lot on the stroke service. So the risk of having a stroke is particularly high the next few days, weeks to months after stroke. I gotta say that generally speaking, that risk goes up, stays kind of stable, and slowly goes down over the next few months after stroke. That time frame is about 6 to 9 months. So you are at a high risk of stroke when you just had one. I just gotta say, when someone is experiencing the signs and symptoms that our colleague mentioned, first you have to call 911 immediately because that will take you to a center that has expertise, right? Not only from doctors, but also for nurses and personnel that can actually expedite treatment to actually prevent further disability from stroke. Those treatments are the clot busting medications, so the tenecteplase, that's the medical term for that medication, and also mechanical thrombectomy, which is a procedure in which we identify there's a blood clot blocking a major artery. We go after that. Actually, one of our neurosurgeons here present do that and retrieve that clot and actually prevent disability and also death. These are disability sparing treatments that are time sensitive. So when we identify those patients, we want them to come right away, get treatment, but also we run, a battery of testing, blood work, imaging to identify actually what led to the stroke. Once we know that, we can actually provide a specific treatment strategies to prevent a stroke in the future. So that comes in a form of pills sometimes injections, and those patients then will have a less likelihood to have a stroke in the near future. If you don't get any of those things, your chances are pretty high in the next few days.
Okay, very helpful. Thank you. All right, next question here, Dr. Middle. This one is for you. For someone who has a family history of strokes, are they more vulnerable for having a stroke themselves?
Absolutely, Sarah. I think the family history is an important piece of the puzzle when it comes to the stroke risk. If one or more of your first degree relatives, your parents or siblings, have experienced a stroke, especially before the age of 65, your lifetime risk of stroke does increase. There are few ways that family factors come into play. And number one, I would like to point out there are genetic and inherited conditions. The first one being familial hypercholesterolemia, which is basically your bad cholesterol levels are very high due to a familial condition. And that can lead to acceleration of atherosclerosis in the blood vessels in the brain, increasing your stroke risk. There are other genetic conditions that are relatively rare, such as CADASIL, and those conditions can also increase your risk of migraines and stroke over time. There are blood clotting disorders such as factor V Leiden mutation, protein C, and protein S deficiency. When there is familial reporting of increased clotting, it is important to get that checked out. Not just that, I do think that family also share the lifestyle risk. You know, their diets are similar. They pretty much eat very similar food, which could put all of them at risk for high risk conditions such as stroke or heart attack. And often smoking and sedentary lifestyle can also be shared among the family members. So it is important to recognize that early and act on those risk factors. And you can also talk to your primary care physician so that they can evaluate you in advance for those risk factors. Some of them could be checking your lipid panel. If there is a family history of blood clotting type of stroke, checking your clotting risk can be important as well. It is also important to check with your family member what kind of stroke did they have. Did they have bleeding kind of stroke, or did they have a clotting type of stroke? And accordingly, you can manage your risk factors to improve your overall risk profile in the long term related to stroke.
Okay, thank you. An important reminder about understanding your risk factors as well. So thank you. All right, before we go to the next question, just a reminder, feel free to drop your questions as they pop up for you during our discussion in the Q&A, and we will get to them at the end of our webinar. But next, we will turn to Dr. Ghosh for our next question here. If someone is having an acute stroke, what are some treatments that neurologists and neurosurgeons offer when they arrive at the hospital? Also, are there interventions that are done that can help prevent strokes?
Thank you. Yeah, so really in the last 20 to 30 years, stroke and the treatment of stroke has turned into much more of a surgical disease. So a lot of times, as my neurology colleagues mentioned, there are things you can do to prevent a stroke. And a lot of times that's lifestyle modification or certain medications. But in the event of a stroke, if you come to the hospital or EMS brings you to the hospital, typically what happens is the first thing you do is you get assessed by either an ER physician or a neurologist, and they calculate what deficits you have. If they are concerned that you're having an acute stroke, then you get a CAT scan of the head. A CAT scan of the head is a very quick scan to look at the brain to make sure there's no bleeding. If there's no bleeding, and sometimes even if there is bleeding, you get a scan looking at all the blood vessels in the brain that Dr. Surya mentioned. An ischemic stroke is when there's a blood clot in one of the blood vessels of the brain. And when there's a blood clot in the blood vessels of the brain, then a certain territory of the brain is not getting blood flow. When all this sort of all these tests are done, that's when both neurology and neurosurgery, as colleagues, make a decision on what intervention to offer to the patient. Sometimes that intervention can just be what's called TNK or TPA. That's a clot-busting medication. That's a strong IV medication that really is a big, strong blood thinner, and that is really a non-surgical way to break down the blood clots in your body. That's a very common thing that we've been doing for years and years. You have to fall within certain specific guidelines to get that medication. However, if there's a blood clot found in one of the blood vessels in the brain and you have a very high stroke scale, which means that you have very significant deficits, whether that's unable to speak, unable to understand, complete paralysis, depending on how debilitated you are, that's when me as a neurosurgeon gets involved in performing what's called a mechanical thrombectomy. That's a surgical procedure where we actually take small catheters and wires. We access the patient's arteries through either their wrist, I usually use the wrist, or the groin, and we can actually go through the arteries of the body into the arteries of the brain and essentially almost like a vacuum, suck out the blood clot and then restore blood flow to the brain. That's a very good procedure that's been shown to have great effects. And, everyone has varying successes. As Dr. Surya mentioned, everyone's brain is different. So some people, they don't have great collateral blood flow. So even if you do the procedure, they can still suffer strokes. I've seen patients in my practice who have, complete paralysis and difficulty speaking. And after this procedure, within 24 hours, they're back to normal. So there's a very wide gamut of effects you can have from surgery. So that's one of the interventions as neurosurgeons we can offer patients if they come to the hospital suffering an acute stroke. On your second question you mentioned is interventions that we can offer to prevent strokes. The main things that we do here is really looking at blood vessels of the head and neck to see whether or not there's a disease that's affecting blood flow to the brain. One of the main things I do is treat carotid disease. So as Dr. Ten and Dr. Mitchell mentioned, if you come to the hospital and you had a stroke or you're getting worked up by a neurologist or a primary care doctor, one of the main things they can do is check with ultrasound to see how much blood flow is going to your brain through your carotid arteries. Sometimes we find people have blockages, the same way people have blockages in their heart and their coronaries. People can have blockages or plaque in their carotid arteries, 50, 60, 70%. And that's a risk factor for stroke because not only can you have less blood flow to the brain because the pipes in your neck are blocked, also some plaque in the neck can fly up into the brain and cause a stroke. So as neurosurgeons, we offer surgeries to open up that plaque. Some surgeries are carotid stenting, where we actually put a stent in the artery. And another surgery is called a carotid endarterectomy, where we actually open surgery, make an incision in the neck, and we clean all the plaque out and kind of close the artery up. Both are very effective. So those are just a brief glimpse into some surgeries we can do to prevent strokes going forward.
Yeah, thank you so much. Really interesting to hear what's possible from a surgical standpoint. So appreciate you walking us through that. Okay, we will turn to our next question here. Dr. Surya, this one is for you. What signs of stroke are most ignored? Is there an annual test to detect early circulatory issues? And last question, and I can repeat if needed, how do you know if veins are healthy?
All right, so there's several questions in there. Some of these were touched upon. I'll do my best to summarize. So, I mean, the most common symptoms that are probably overlooked would be sudden confusion, sudden fatigue, and sort of general weakness that are people just can't tell. Especially that may happen actually more in women than men to some degree. Those can all be subtle signs of stroke. And of course, anytime a symptom gets better and it resolves quickly, that could be dismissed. But that could also be the sign of a transient ischemic attack, in which case a blood vessel is actually being blocked, and then the body can naturally clear it. So even if something goes away, I think a lot of us we'd rather not go to the emergency room and the doctor. But if that happens, we hope that from this evening on that you actually do get it checked out because that can be a red flag. And as Dr. Ghosh just said, there actually, and Dr. Ten and Middle, there actually are tools that we have now that if we catch things in time, we can make a huge difference in one's life. In terms of screening, I think it's the same common sense we all learn from your primary care doctor, the same for your heart health and the health of your arms and your legs. That's regular checkup of your blood pressure, cholesterol, blood sugar. All of those are very important for stroke risk. To what Dr. Ghosh just said, we can look at the ultrasound of the neck. Sometimes the doctor will listen with a stethoscope and then proceed to that, and that can help with those blockages. And the sooner you know, the better, more you can do with it. In terms of the veins, so look, we get older, not younger in life, and so our blood vessels sometimes don't, not only can plaque collect, they can be less pliant. And so, the most important thing to maintain your overall health of your arteries and your veins in your body is, in addition to what I just said, which is, having your primary care doctor, your primary care nurse keep an eye on your blood pressure, your cholesterol, and your blood sugar is just lifestyle. Just having a healthy diet, sort of a Mediterranean diet, fruits and vegetables, not as much red meat, that kind of thing, and regular aerobic exercise to what you're able to do, and healthy sleep, right? Having a good sleep schedule. All those things are going to really help the overall body be as healthy as it can be. And we obviously in a forum like this we can't really give customized information, but this is more if you're asking these questions, those are the right questions to ask. And I would strongly encourage people to ask your primary care provider and ask whether it's a physician, a surgeon, a nurse, whoever it is, and ask them. And actually I would say I'd go a step further. You all had the motivation to show up and ask these questions this evening. be assertive. Don't just be like, oh, well, what happens, happens. Be saying, no, no, I want to take care of myself as much as I can. Like, I'm all right, my blood pressure is okay and I don't smoke, but I want to go further. Like, how can I really push myself in a safe way to keep my blood vessels and my brain as healthy as possible? And you may actually like snap them out of it and they'll give you some real attention.
Absolutely. I think that's a great point about just being your own best self advocate. So, a great reminder. Thank you. Okay, next question here, Dr. Ten. This one is for you. What are the three best things that can be done for stroke prevention?
Thank you. Sorry, I was trying to answer a question on the chat, so we'll be
Oh,
sent
yeah.
pretty shortly. But I guess that's a hard one to answer in one, just labeling three. But I'm going to say stay active. So physical activity is important. Stay healthy. So eat a balanced diet, right? Mediterranean diet, like Dr. Saruya was saying. Quit smoking. Avoid excessive alcohol intake. That's how you stay healthy as well, and control your pre-existing medical conditions, such as hypertension or high blood pressure, right? High sugar levels or diabetes, high cholesterol levels, and make sure you have good follow-up with your primary care doctor, family doctor, and for those who had a stroke, also with your neurologist.
Okay. All right. Really helpful tips to keep in mind. Thank you. Okay. Next question here, Dr. Middle. This one is for you. Can you suggest any strategies to strengthening memory?
Sure,
Interesting.
Sarah. So, memory changes are common after stroke, and many people can improve with time, support, and specific strategies. I would say, first of all, it is very important to understand why memory changes happen. There can be areas of the brain, such as hippocampus, that can be affected by stroke, which is impacting your memory. Not just that, often post stroke depression, stress, fatigue can also impact your memory. And it is important to talk to your doctor about what type of memory was affected due to the stroke. Some of the strategies that can really help is keeping a routine, keep your daily tasks the same way you wake up and continue with your daily routine. So keeping that same task oriented, on daily basis is definitely going to help with your overall recovery from stroke. Writing down reminders for events that are important or in general for day-to-day activity would be helpful as well, and breaking things down, such as associating things with, let's say, associating a name with a flower, like let's say Rose. Somebody's name is Rose and you associate it with the flower. So association of things can be helpful. Sometimes grouping things, such as chunking of things together, can also be helpful in the memory recovery. Um, Exercise is definitely known in research to improve your recovery. Walking every day can be definitely helpful with overall memory recovery. Brain games such as puzzles, solving puzzles, crosswords can also be helpful with the memory recovery. Making sure that you get good sleep. I think 7 to 8 hours of sleep is extremely important to make sure that you are recovering from stroke in general, and especially your memory. And the other things, that there are medications out there which may be helpful in memory recovery, and getting a neuropsychological testing could help further pin down the exact kind of memory issues that you may have from the stroke. So I think that is also very important in your post-stroke rehabilitation.
Okay. Thank you. Some really important tips to keep in mind. So thank you for walking us through that. Okay, we will go to our next submitted question here, Dr. Ghosh. Let's talk a little bit about recovery. So in general, how long does it take to recover from a stroke? And is a full recovery possible?
Yeah, so this is a very good question, and it's obviously something that people care the most about. A lot of times, you know, I would say the answer is very variable, and it's very depends on every single person. What we've learned is every single person's brain architecture and sort of their collateral circulation is different. What I mean by that is every single patient has different blood vessels. So, one patient, if they have a blood clot in the left side of their brain, and they go without blood flow for, let's say, 2 hours, and another patient has the exact same blood clot, both those patients will have completely different outcomes because one patient may have other blood vessels supplying that territory. So certain blood vessels are not as important, while the other patient, for whatever reason, may not have as much collateral, not have as much backup to help them. So in those situations, they're much more reliant on every single blood vessel. So really, as Dr. Surya mentioned earlier, everyone is different and everyone's recovery is different. What we care about a lot of these times is this idea of what's called penumbra. And what that term essentially means is once there's a blood clot in the main artery of the brain, by the time people get to the hospital, they're really the blood vessels, brain tissue starts, dying or infarcting within 5 to 20 minutes. It's very, very quick. However, that doesn't mean necessarily the whole territory that the blood vessel is supplying is going to die within 5 to 20 minutes. What happens is things slowly enlarge as time goes on. So by the time people come to the hospital, there's usually a core infarct, which means there's a small area of brain that's been damaged, sometimes irreversibly. However, what we want to do is preserve the secondary areas around that core, the areas that are more fed by collateral circulation, and that's what we want to get to make sure that survives. Regardless of what we do, recovery is different for every patient. Typically, what I tell people, and if you ask 10 different surgeons and neurologists, they'll all have a different answer for this sort of response. Typically, what I tell patients is recovery can take 1 or 2 years. And if at the end of 1 or 2 years, things have plateaued, significant recovery after that may be limited. But usually this is not something that recovers in days to weeks. I tell patients it's a months to years sort of cycle. However, I won't say that full recovery is not possible. I've seen the gamut of patients. I've seen, people who, were hemiplegic and aphasic, and 6 months later walked into my office, with minimal symptoms. So for every patient like that, there are people who unfortunately don't recover. So it's very, very variable. A lot of that depends on your overall health status, how diseased your blood vessels are in general, your other comorbidities, how well you can participate in rehab. So a lot of that goes into everything. So everyone is different, but short answer to a long question, full recovery is possible, but it's very variable. And I think one of the things Dr. Surya will get into is what else we can do in terms of recovery besides rehabilitation that can aid in patients' recovery.
Exactly. Getting into my next question. Thank you. All right. Dr. Surya, we will turn to you now. What is the role of neurostimulation for stroke recovery? If you could talk about that.
Oh, can I talk about that? So I love that. So the short answer is that we now today in 2025 actually have some pretty remarkable new treatments available for stimulation. So one of them, so when we say stimulation, we mean using electricity, so gentle currents through a stimulator. It's already today, and it's been for some time, part of standard of care as part of when a physical therapist or an occupational therapist works with someone who's had a stroke, that they can apply little stimulators on the body. Some of them are called functional electrical stimulation or a TENS unit to help with pain. Some to help pull the shoulder back in place because sometimes after a stroke, the arm gets weak and sort of its weight pulls itself out. And those are actually can be very helpful options that I think are quite underutilized. So I think that's one thing many of you, if you're having some of that discomfort or mild weakness, that you can ask an occupational or physical therapist if they could, work with you on that. But a more recent exciting thing is where we do paired nerve stimulation. And one of the approaches that was approved in 2021, and that we're proud that Jefferson is the lead site for this in Pennsylvania, and actually one of the top 5 in the whole United States at providing this, including with the surgeons like Dr. Ghosh in New Jersey, as well as at downtown Center City, is called ViviStim, which is a vagus nerve stimulator. So we have these vagus nerves in our neck, and we specifically implant in a little tiny stimulator, very close to where Dr. Ghosh said he would do that carotid endarterectomy. But rather than going to the carotid blood vessel, you're going to this nerve bundle that communicates between your middle, your heart and your spleen and things like that, and your brain. And it's a way of applying gentle electrical pulses that go up into the brain. And I often think of it as like an electrical ice bucket challenge. So once the surgeons implanted it, a few weeks later, a occupational therapist has like a little remote control clicker, sort of like, when you want to turn on the TV or trigger something remotely. But in this case, it just sends these gentle pulses that sort of wake up the brain and that are coupled to a specific kind of skilled therapy. And this has been approved by the FDA. It's been reimbursed by Medicare, Medicaid, and various private insurers. And it's the main target of it is to restore hand movement in people who've had an ischemic stroke. And it doesn't matter whether someone's had a stroke 3 months ago or 30 years ago. It's been shown that it can be effective. It's not necessarily effective for everybody. Again, there's a lot of variability, so it's important to be assessed by an occupational therapist. If someone has not even a flicker of movement anywhere in their body, it may be very difficult to sort of retrain the brain. But there is a kind of group of people that now this is possible. So this is actually available at Jefferson. You can ask any of us, the primary care doctors. In fact, Jefferson Marketing previously set up a website, jefferson.edu/restore, the word restore. We had like a billboard educational session, and that's still active. If you go there and put in your information, then someone on our team will get back to you and route you to the right person so you can get the evaluation. It typically starts with an occupational therapist who will then sort of see if you're a good candidate. So we're very lucky. And this is actually an example of the fact that now Jefferson is part of Moss and McGee. We're all one giant family, and we're spread across throughout Pennsylvania and New Jersey. And we have a network of I think there's like 7 or 10 therapists that are specialized in this unique electrical stimulation technique, which is really remarkable, right? So that it starts in the operating room with someone like Dr. Ghosh, and then over many weeks, you work with a trained therapist who sort of teaches that penumbra that Dr. Ghosh was talking about, sort of strengthen its connections to regain some strength in the hand. And although they haven't gotten FDA approval for it, we know anecdotally that it actually can help other aspects, not just the hand. That in certain people it helps with their walking. It can even help with their speech. It can help with mood. It helps with some other things. It's not approved for those reasons, but we've observed that. And the other thing I'd like to point out is that we're also a site for upcoming trials. So if someone's not a candidate for that, there could be some other options. And that also, I think a little earlier you had asked you had relayed a question about, what are your what kind of things can you do to take care of yourself and an annual check-in. And what I really want to convey to everybody is that not only do we have this treatment today, but there are amazing things being done in the laboratories and things that I'm honored to be part of, where we're able to literally rebuild parts of the brain and put them back together. And if any of you want to be a good candidate for those, then the better you are at maintaining a healthy blood pressure and a healthy blood sugar and a healthy blood cholesterol and having as much exercise as your body can safely tolerate and a healthy nutrition, the more likely you're going to be a candidate for treatments like that. So, for example, if you're going to see Dr. Ghosh in New Jersey to put in the stimulator, he's going to make sure that your blood sugar isn't through the roof, because if it is, then you're not going to have this great healing. So even though sometimes these things seem so far apart about, keeping exercise, sleep, and exercise versus a futuristic implant, these are all so connected. And as you mentioned earlier, you each have to be your own champion. That if you take care of those things, you're going to be at the top of the list of being able to qualify and benefit from these.
All right. Well, thank you so much. It's really exciting to hear about some of the work that you're involved in. And as you said, just connecting the dots. So appreciate it. All right. And along those same lines, Dr. Ten, I do want to turn to you to continue talking about advancements. So if you don't mind just talking a little bit about any new technology for neurological rehabilitation, that would be great.
Yeah, that sounds good. And thank you, Dr. Saruya, because that I cannot top that explanation, right, about that nerve stimulation. So thank you so much. I will try my best to explain it the way a neurologist understands it, right? Who's not involved in the implantation of that device. So I just want to start saying to all of you that the technology that we use for stroke rehabilitation is based on your specific needs, right? Every stroke is different, and you're going to have different sequela or disability from stroke. So the stroke rehab will be targeted based on your specific needs. Particularly, and I'm sure some of you know, but I'm going to just refresh everybody's mind on what are the needs that a patient with stroke will have. So you can have needs for physical therapy. So let's say you're going to be unable to walk because you lost your balance with the stroke, or you happen to have a leg that is dragging and you need coordination or help with coordination. You could have occupational therapy needs, which we call it OT most of the time, right? And that means that you're going to have difficulty using your hands or your hand or your arms and buttering your shirt, yeah, right? Combing your hair, petting your dog, right? Or your pet. People can have some speech difficulties or swallowing difficulties. So that's another domain that a stroke rehab is geared towards too. And also you can have cognitive issues, right? From a stroke, Dr. Mito actually explained earlier today. And for those, we first have to have a one-to-one, discussion with the patient, meet the patient, examine the patient. Typically, we have qualified personnel that it's certified in rehabilitation services, and we apply. They apply different techniques and modalities. There are two big buckets, and that's how I understand that from the rehab standpoint. When I have to explain this to my patients in the stroke service or people who come with a stroke, you have physical instruments or tools that you use, treadmill, weights, whatever that may be, right? So tools that actually tackle the specific needs of you, the patient, and technology that we use to help ourselves with that need. So for instance, we have technology as exciting as the vivitism, as Dr. Saruya mentioned, but we also have technology that is at the fingertips of the patients, right, of you guys. We have Amazon things that we can order. Typically, that's led by the therapist or the rehab physician. And we can, have computer games, we can have video games tackling specific needs, right, for the patient who have those issues. We have virtual reality, actually. A couple of years ago, I was actually in some sort of demo for that, where you will wear the goggles, right? And we will play like the patient, right? And kind of like enhance your arm movement or your leg movement, depending on what it was, balance with virtual reality technology. And also we can get very, very fancy and use robotics for the rehab treatment. And again, that's provided by qualified personnel. There's a lot of rehab devices in the pipeline, waiting to be, get out there. A lot of homegrown and also international research on that. And regarding the robotics, I just want to mention, the exoskeletons, which are like external things, almost look like a little robot, right? That people, especially with spinal cord injury, sometimes it's been in use to actually improve mobility on those patients who actually otherwise cannot stand by themselves, right? So I think with the nerve stimulation, which is part of the technology, right, that Dr. Saruya was mentioning, the way I understand it is like, we are going to focus on stimulating a specific nerve that will send signals to the brain, right? And help the brain to almost, kind of get excited, release all these substances that rearrange the work of certain brain cells. And therefore, we try to recruit neurons or parts of the brain that are working, that are not affected with the stroke, and almost kind of like train them to do the work of those neurons that are already injured in the brain. So again, everything is very personalized, is evidence-based, but has to be geared towards a specific goals based on your needs, physical, occupational, speech, or cognitive. So you can actually live and enjoy your life as you know it. If you like to jog, then continue to jog, right? Um, Walk your dog, just live a life that we all enjoy. I think that's the best way I could summarize it. And hopefully, I'm not sure if there are any questions about that, but we'll leave it there for now.
Yeah, and we can get to any questions. We're just about to turn to the live questions now. So if people have questions, they can definitely feel free to chime in.
Can I, can
Thank
I
you. Yes,
Can
please.
I just add on to what Dr. Ten said? So that was excellent. Again, I want to reiterate that in the Jefferson Moss McGee system, we have a lot of really amazing opportunities. So not only do we have ViviStim, Dr. Amanda Kingston, who's based at the Abington Hospital, part of the Jefferson Network, offers repetitive transcranial magnetic stimulation, which doesn't involve an implant, if there's post-stroke depression. So, in addition to the medications like Prozac and Zoloft, and of course, talk therapy, there's very clear data that can be very effective. that there are these other options, which is another kind of stimulation. And in addition, Dr. Ten just mentioned the cool kind of computer game. So Moss is actually a world leader and with McGee on offering some trials. And there was one that's actually coming out very soon, later in 2025. It actually is somewhat amusing. They built it by talking to thousands of people at stroke, and they asked them what were the most enjoyable games they did when they were children. So they've created this very unusual sort of video game that you're at your home, and they give you this kind of control pad that's sort of based on a carnival game. So you like play whack-a-mole, and with these funny things. There's not actually moles popping up, but it's sort of modeled off of that, so that it's sort of fun and enjoyable. But it's that same kind of technology. So some of these things are going to be in development for years, but it's important for you to know that your occupational physical speech therapist may actually have tools today that are available. And if your particular occupational or physical therapist near your location doesn't happen to know, you can always say, "Hey, you're part of the Jeff Moss McGee network. Why don't you contact the ones at the mothership, like at Elkins Park or the other places?" And they can and will refer to you, and your insurance should cover that, and they can expose you to these other options. And of course, there are the clinical trials, like I mentioned, like this crazy whack-a-mole one, which you could be a candidate for. And, with research, you obviously can't promise the same benefits. But on the other hand, you're being altruistic. So no matter what happens, you're sort of paying it forward to the people who have the stroke in the future. And so I think that's another sort of amazing opportunity here that all the things we talked about, whether it's weakness or numbness or pain or cognitive or depression, all these things, or speech, there are tools we have that we can push and get better, both tools for today and then developing trials for the treatments of tomorrow.
Yeah, it's again really incredible and exciting to hear everything that is out there. So thank you both, Dr. Ten, Dr. Surya, for walking us through that. But yeah, with that, I think we'll go ahead and jump into our live questions because we've been receiving some from the audience. So thank you all. Dr. Surya, I will actually start with you because something you just mentioned is a great follow-up to this question here. This person is wondering, so after a stroke, there's depression, and what can be done for both, and how are they related? So I know that you just mentioned that, so I'd love to
Yeah,
get
sure.
your thoughts.
So when people have depression after a stroke, I think it's important to understand there's usually two things happening. One is that we call a secondary depression, which is that anyone who couldn't suddenly control their arm or their speech is going to be depressed. It's depressing, right? It's upsetting. It's a normal, healthy response to become depressed when suddenly your life is turned over because you can't do the same things you did. And that's very important to sort of just recognize that feeling depressed isn't always an abnormality. It's actually the rest of your brain is saying, this sucks. And I can't live the life I used to live, right? So that's number one. But number two, it's also important to realize that some of those brain tissue that all my colleagues have been talking about, some of it is the basis of your emotion. And if you have a stroke that damages your mood circuitry, the circuitry that allows you to be happy and satisfied, that also can make you depressed. And that's not an issue of your will. That's actually just like you could injure a part of your brain that affects your arm from moving. You can damage a part of the brain that has to do with your ability to experience certain kinds of happiness. It doesn't mean that you can't find happiness again. It means that that circuitry just has been injured and you need to find a workaround. So I think just having that understanding sort of gives you a framework to sort of then work on a plan. And I think the main thing to realize is that the types of approaches that work for all kinds of depression can be also very effective in stroke. So the antidepressants, I mentioned the magnetic stimulation, and there of course there are clinical trials of new novel things like ketamine and all kinds of things being investigated. But just the standard of care options can be very effective. And so I think unfortunately, because there's so much specialists and doctors' appointments can be so brief that sometimes what happens is someone will be put on an antidepressant and they kind of float through the months and the years, even though they really are continuing to have a pretty serious depression and the family knows it. And so I don't think we have to settle for that. That doesn't mean that you have to go and demand and say, make me 100% happy instantly. But I think it's fair to say, hey, I've been really down and I've had this low energy or I felt really this sadness and guilt, or the family members can notice that. And don't just accept that. Just say, well, can we try a higher dose of a medicine? Can we try different medicine? What about a magnetic stimulator? So I think just like I said with the physical exercise, you kind of have to push back and don't just accept that. Sort of say, well, what else can be done? And even sometimes it requires a little creativity. So again, I'm not giving specific advice, but just as my personal examples of people with post-stroke phenomena, sometimes I will give them a low dose of a stimulant. And they think, oh my gosh, something like Adderall and someone who has a blood pressure problem. Well, that's why we're doctors. We have to sort of figure out for that person, and Dr. Ten, actually all the docs, we're saying that each person is different, what's going to be safe and beneficial for those people. But in the right person, in the right time, there actually can be these tools. So you have to sort of speak up. And the other thing I think is really important to mention about depression, especially for loved ones, but even for oneself, if oneself had the stroke, is that if someone seems really apathetic and withdrawn, that's not that's don't think of that as like a issue of willpower, right? Like, oh, why aren't you trying more? Get out. So that can be involuntary, related to the injury of the stroke. And so in that case, if you say, well, why don't they don't want to go for a walk anymore? They don't want to go do XYZ hobby. What I usually tell people, especially the family members, I say, don't argue with the person because it's not voluntary. It's not like a will issue. Instead, almost say, we're going for a walk. Don't make it a choice, and you go for a walk, and the person says, "Well, I don't feel like it." You don't feel like it. We're going anyway. Now, again, each situation is a little different, but I think if you realize that sometimes that apathy, that lack of energy, is not always voluntary, it's actually either part of the stroke or the post-stroke depression. It kind of, again, you don't argue with it. You sort of say, "Well, let's just build these habits around this person to sort of just encourage them," because nine times out of ten, the person who's like, "Oh, I don't want to do that," once they're doing it, once they're out at the concert or out in the woods or whatever, going fishing, they're happier. And so we don't want to lose that opportunity. And so just having a little bit of knowledge about it, you can go a long distance. But again, you got to focus with the particular doctors, the nurses and therapists that but just to open that idea that post-stroke depression is treatable.
Yeah, yeah, that's a really important point. So thank you for going into that. We appreciate it. Okay, next live question here. Dr. Middle, I will turn to you for this one. Are those who've experienced severe migraines for more than 10 years at risk for stroke? And this person is wondering, is there any correlation between the two?
Sure, Sarah. So I think there is definitely evidence that genetic conditions such as CADASIL, there is increased risk of stroke and migraines together, but that is a very relatively rare condition. In general, research has shown that there is slightly higher risk of stroke in patients with migraines. The duration of migraines does not necessarily change your risk of stroke, but I would say treating migraines is overall important for your quality of life and for your brain health. So we do not recommend any specific testing for patients who have migraines related to stroke care. But if you are concerned about having focal neurological symptoms such as numbness, such as weakness on one side of the body, or difficulty talking while you are having a headache, it is very important that you seek emergent care to make sure that is not a stroke. What is sometimes may look like a migraine could end up being a stroke. So it is important that you seek emergent expert care so that you can clarify whether it is a migraine or a stroke.
Okay, thank you. All right. Next question here. Dr. Ghosh, this one is for you. No, we talked a little bit about this earlier, but if we could kind of expand, this person is wondering, what is a mechanical thrombectomy and how is it different from other stroke surgeries?
Great question. So really, it's like the mainstay of our surgical treatments for acute strokes. So if a person comes to the hospital and they have a blockage in one of the main blood vessels in their brain, so for example, the middle cerebral artery or the basilar artery or the vertebral artery, these are all blood vessels that are in the brain. If there's one or more of those blood vessels are blocked in the brain, mechanical thrombectomy is the surgical procedure that we perform to retrieve that blood clot. So what that is, like I mentioned previously, we take literally little tubes, little catheters, and little wires. We can put needles into the wrist or the groin. Through the arteries, we actually take those, we actually take those tubes under X-ray, and we can navigate those tubes through the arteries of the body into the brain. So for example, let's say we go through the arm, we go through the wrist. We use X-ray. We can navigate a little wire up through the arm, into the chest, up through the neck, into the brain, all under X-ray. We can actually see on X-ray as we inject dye where the blood clot is, and we can go through that same hole in the artery. We can go and retrieve that blood clot using those little tubes and wires. So essentially, it's just a fancy way of saying we're mechanically removing a blood clot to restore blood flow to the brain.
Okay, thank you very much. All right, next question here. Dr. Surya, we will turn back to you for this one. This person is wondering, what has happened with the study of the neurosleeve, and is it still a viable study? And what is the criteria to get into the study?
Yeah, so the neurosleeve is something we invented here at Jefferson. We're proud of. It's an upper extremity assistive system. So it's something you wear on the body. It can help open the hand, open and close the hand and move the elbow, and even sometimes the shoulder. And it can either use a brace that's 3D printed or a stimulator. So the clinical trial is on pause because we have so much data from our previous participants who had stroke that that Jefferson is trying to make it commercialized so that it's actually available and covered by people's insurance. So we're kind of in an in-between limbo zone. What that means if you're interested, uh, sort of being on the waiting list, sort of to be first in line as we make it available, then you're welcome to contact me. I believe that the marketing team can share my contact information, MDS014 at Jefferson. They can share that, and we can put you on a waiting list. So we let you know when it is available. And also can sort of we have I've prepared sort of a list of other options in the meantime to consider. So that's the status. So thank you to the predecessor individual with stroke. They gave us a lot of feedback, and there are people out in the community who are using it right now. But based on that, contributing to a trial, we're making the treatment tomorrow. We hopefully in the coming months, year or so, we will have this commercially available.
Okay, great. Thank you. All right. This next question, whoever wants to jump in, feel free. This person is wondering, we're looking for stroke rehab. What should we look for, and how to judge if one place is better than another? And whoever wants to chime in, feel free.
We want you go first, Dr. Ten.
Yeah, that's okay. I was just waiting to see, but I would say, what I would do as a patient, I usually look at the websites and check them out. Where about like if I have someone that I know that had been through a disease that needs, some sort of follow-up care, word to mouth kind of thing, and it's what works for most people. But I will check the websites. I will make sure these rehabs are certified by some sort of entity, the Joint Commission. There are other state and regional levels of certification. I think it's very important to get the care in a place that you have professionals that are certified on providing that care. I think that's key to picking up the place. Of course, I'm positively biased regarding our rehabs because we have really the best rehabs in town. So as you know, I work at Jefferson Einstein. I'm the chair of neurology there, and we have a great collaboration with Moss Rehab. So, and we know that they're not only great at bedside, they also have well-recognized doctors, not only nationally, but also internationally, right? So having those big leading clinical trial people really help me be comfortable as a stroke neurologist to send my patients for rehab care. That's what I would do, if I were to choose where to go. But Dr. Sarui, I'm curious, what would you do?
Yeah. So just echoing Dr. Ten, we are actually very fortunate in Philadelphia and Jefferson in particular of having this relationship with Moss McGee, which used to be separate. In the last few years, we're now one big family, which sometimes it's like a weird marketing exercise, but it actually translates into benefits for all of you because now all of us on this call sort of get to work with each other and our physiatry, physical medicine, rehab colleagues, and actually get to know the occupational and physical therapists. So I think obviously depending on where you live, if you're dialing to this Zoom from some distance, you kind of you want to do whatever's closest to you. Although I should say that usually insurance companies, it may be a little tricky, but they will let you kind of move between different offices so that you can learn some key techniques from one and then bring it back more locally. There's a little bit of finagling you can do. But I would just say, really, anyone in the Jefferson Moss McGee network, to going back earlier to the ViviStim, we have a network of 7 sites that have occupational therapists that are certified in assessing people for ViviStim. And those tend to be the people that also know, like the fancy robotics things that Dr. Ten just mentioned. So like Moss Elkins Park, McGee Riverfront, both of those sites are sort of the 2 main hubs, and to some extent also developing in New Jersey, Jefferson, Washington Township. So I think we have it's sort of like hubs and spokes. Thankfully, all the therapists sort of talk to each other. So if anyone's in the Jeff Moss McGee network, they sort of share their knowledge across each other. So I would recommend if it was me, if it was my loved one, I would definitely try to get a Jeff Moss McGee, occupational and physical therapist, speech therapist. I would try to be in that system, and I would ask them the questions you heard about tonight. Would say, are you familiar with ViviStim? Are you familiar with robotics? Even virtual reality? Are you familiar with clinical trials? Do you know any neurosurgeons and neurologists and like because again, I think that's something really unique here at Jefferson Moss McGee is where I was just at a meeting last week. And I met some of Dr. Ghosh's colleagues in Washington Township, and they were on a first name basis with the occupational therapist. And that's actually unusual that people that are taking care of you in the emergency setting or in a surgical operating room setting are becoming colleagues and communicating about your care with the colleagues that are spending all these hours and months of work. So we actually have those relationships here. So my recommendation is stay in the Jeff Moss McGee system. That if you see Thomas Jefferson and his ponytail wagging, like go that way.
All right. Love that direction. Thank you. Okay. Next question here. Believe this was answered in the chat. Someone had asked the difference between a heart attack and stroke. And I know Dr. Ghosh and Dr. Middle, you responded, but if you don't mind just talking live, I think it's an important question to address for the rest of the audience too. So Dr. Ghosh,
Hey, Dr.
yeah.
Hatto, go ahead.
Sure. So I would definitely emphasize like that a stroke, think of it as a brain attack. Like the heart attack is the stoppage of the blood flow to the heart blood vessels. Similarly, the stroke is due to blockage of the brain blood vessels, or if a blood vessel in the brain bursts, which is a hemorrhagic stroke. So there are 2 different things of base affecting 2 different organs. And it is important to understand that time is the key in both the scenarios. Time is brain, and it is very important to take emergent action and call 911 if you are experiencing stroke-like symptoms that one of my colleagues mentioned earlier, be fast. So if you are experiencing any balance issues, any vision changes, face drooping, arm weakness, speech difficulty, it is time to call 911, which is the sign of stroke or a brain attack. And it does not mimic heart attack usually, but can be associated with chest pain-like symptoms as well. So time is brain, and I wanted to make sure that everybody understood that in case of any signs of stroke, do not drive to the hospital yourself. Make sure that you are calling 911. That will bring you to the closest hospital to your home so that you can get the care that you need. And one more thing that I would like to emphasize, often when patients experience heart attack-like symptoms, they will take an aspirin. But if you are having any stroke symptoms that we just talked about, do not take an aspirin because you could be having bleeding type stroke as well. So you first need to get a CT scan before you can take the right medication based on your CT scan results.
Okay, thank you. Important call out there. All right, and Dr. Middle, another question for you from the audience. This person says, you said you do telestroke. Do you mind just telling us about what that is? And is that something I can use if I'm having a stroke?
Absolutely, Sarah. So telestroke is basically seeing a patient that is suffering from stroke symptoms in an emergent setting with the help of a video call. And we are able to assess the patient timely because stroke experts are not available everywhere across the country. But with the help of this video call, with the robots that we have across several hospitals in the country, with the help of Jefferson and other systems as well, that we can provide this same stroke expertise that is available in the Center City emergency room to other emergency rooms in the area. And because time is brain, as I mentioned earlier, with the help of telestroke call, we can make all those decisions regarding the clot bursting medication and talk to our neurointerventionalist colleagues, such as Dr. Ghosh, and make that timely decision regarding the need for mechanical thrombectomy. So if you are in the area that is served by one of the Jefferson telestroke systems, then we are able to provide you that same exact care that you would get at Center City, at any of the community hospitals that is served by us.
Okay. All right. Great. Thank you. Okay. We're going to do one last live question here, and then we'll wrap up for the evening with a final question for myself. So this last live question here, Dr. Ten or Dr. Ghosh, if you want to jump in, what are the latest stroke clinical trials that are hopeful for stroke recovery and rehab?
Okay, maybe I will take that first. I think there are plenty of studies out there. It depends on what exactly we're talking about in stroke. I just want to say, from the patient standpoint, when we decide where to go, like if we have the chance to decide and we're not having acute symptoms, right? We're not having acute onset of stroke. The decision of where to go usually comes from where is that we can get the best care? Where is that they're following science, right? And usually that comes with this kind of conversation. So which are the doctors who are out there educating the community, participating actively in research to actually lead stroke treatment in the area. So we can talk about a lot of stroke trials in the pipeline right now. I'm not going to mention one in particular because there are plenty. It depends on which area of the stroke we're talking about. But if we are interested as patients to get the best care, typically the hospitals that have the personnel that is invested in not only caring for you and answering your calls, answering the questions, but also in leading the way in stroke care, typically participate in clinical trials and do research to actually, change practice eventually, right, in their system. So I'm just gonna leave it pretty broad there for the patients because there are plenty of strokes and things, techniques, treatments, devices that we are actually investigating as we speak that actually will lead the way in the future on how to best take care of a stroke patient.
Okay, thank you. And Dr. Ghosh, anything you'd like to add?
No, I think my neurology colleagues answer everything perfectly.
Perfect.
I can just say that, there, as Dr. Ten said, there are a lot of trials going on. There's a lot in development. There's a national plan through the National Institute of Health called StrokeNet. And again, Jefferson Moss McGee is a member of that. So that actually makes certain national trials available to us that wouldn't otherwise be available. That includes that whack-a-mole study. Dr. Rosenwasser, who's the director of the Farber Institute of Neuroscience and is a vascular neurosurgeon who's actually invented some of the treatments that Dr. Ghosh and others have used today, is part of developing a stem cell trial that should be available in the coming years for post-stroke recovery, doing a very unique path. So there are a lot of trials ongoing. I think, as Dr. Ten said, meet with your neurologist, neurosurgeon, physical medicine doc, and they can help you look that up. If you're very interested on your own, you can go to clinicaltrials.gov, and you can go by your zip code or your city, and you can restrict it by what are the active trials. Again, it may be a little confusing if you're not familiar with it because it uses some technical terms like ischemic and hemorrhagic, like we talked about this hour. But it's okay to try to sort of educate yourself and then go to see one of your doctors and sort of ask them to sort of walk you through it. That's something I do all the time, is try to let people empower them and educate them on what the options are out there. And I would like to just lastly say that we're actually in a very unique and interesting position here at Jefferson with my neurorestoration team, that we actually can also co-design trials with all of you, right? So if you say, well, I can't find a trial that does X, Y, Z, you can contact me. And if there's enough people reaching out, we can say, well, maybe we should do that trial, right? So that's really unusual and special. And we're very, very proud of being able to do that.
Absolutely. All right. Well, thank you for raising that. And with that, I want to go ahead into the last question for the evening. And that is, what are your goals for everyone listening in on this webinar? So I'd like to know, what would you like viewers to take away from tonight? So with that, Dr. Surya, I will go ahead and start with you.
So every day is a gift. I think hopefully that you will walk away from this, or move on in your life from this, realizing that there is a lot you can do for yourself and being proactive, or for your loved one that's had a stroke, to address all the preventative risk factors. To be aware that if, God forbid, there's like acute stroke, that they're going to a certified stroke center like Jefferson Moss McGee, you get superb care, and that even months to years later, that there are these opportunities. Some are clinical care options, and some are investigational trials, so that those opportunities are there for you.
Okay. All right. Thank you. All right, Dr. Ten.
Thank you so much. Thinking about that question, I think for you audience, most strokes are preventable. Remember this is you have the control, you have the power. It's in your hand to actually reverse, the outcome of a stroke. If you are in the right path, doing the right things, and have a stroke, then remember that time is brain. So pick up that phone, dial 911. They will take you to the closest, certified hospital, right? Able to take care of stroke patients. We will provide medication or surgical interventions to reverse that, prevent death and disability. So time is brain. Remember that.
Thank you. All right, Dr. Middle, any final remarks?
Sure, Sarah. So I would definitely encourage everyone to prioritize their brain health. I think we all talk about taking care of your health in a way where it is related to the weight or it is related to the heart. So prioritizing your brain health, seeking care timely, as Dr. Ten mentioned, time is brain. Every minute, 2 million neurons die. So you need to seek emergent expert care right away when you have any signs of stroke. And remember, be fast. Balance, eyes, face drooping, arm weakness, speech difficulty, and it's time to call 911. So there is research out there. There are guideline-based treatments that are available at Jefferson Hospital and all the sites that are served by Jefferson physicians. And we bring all the care that we have in Center City to all our sites. So no matter where you are, you will be provided the highest end of neurological care at all the Jefferson sites, from initial recovery process to the stroke rehabilitation. So we are here to help you in any way that your health needs.
Thank you. All right. And finally, Dr. Ghosh, any final remarks?
Yeah, perfect. I mean, just wanted to echo what everyone else has said. I think really from this webinar, the really two things to focus on are both preventative and reactionary. A lot of times, people don't realize what the health of their blood vessels. They don't realize they have AFib. They don't realize they have DVTs, or so a lot of times the first stroke is the first time they realize they have these underlying medical conditions. So as Dr. Mittal and Dr. Ten said, do not wait if you have any symptoms. That can be as simple as, minor numbness in the face, go to the ER, call a hospital. Some visual disturbances, blurry vision, that can even be a stroke, a blood clot to the eye. I've seen, we've all seen various symptoms that were actually showed, carotid disease or a hole in the heart. So do not wait for anything. Any minor or major neurological symptoms, head to the ER and get evaluated. And number two, once you had the first stroke, if in the unfortunate setting you had the first stroke, hopefully it's minor. Do everything you can in your power to prevent the next one. That includes getting involved with neurology postoperatively. If you need a neurosurgical opinion, reach out to neurosurgery, whether it's carotid disease, intracranial stenosis, whatever it is, to make sure the next stroke doesn't happen. Be very active in your rehabilitation. All these things, you may not be able to prevent the first stroke, and that may be a wake-up call to what's going on in your body, but you should definitely be able to prevent the next one.
Okay. Thank you. And I think that goes back to the overall theme of being your own best self advocate. So thank you. All right. Well, thank you so much, Dr. Saruya, Dr. Ten, Dr. Middle, and Dr. Ghosh for your time this evening. Such great information was shared. I know I learned a lot. And I want to thank you all for attending and submitting such great questions and being your own best self-advocate. We will be posting an event survey so you can let us know your thoughts. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to also visit jeffersonhealth.org to make an appointment. You can stay up to date on upcoming events and webinars just like this and more. A recording of this event will also be sent to you so you can rewatch at your convenience. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a great evening. Good night.